Well, thank you for checking into this Dentsply Tulsa Dental program on case selection. We have Dr. Kinra with us today to give this. You can see much of his experience and resume listed on the right just below his video, and if you can't see it all, you can certainly scroll up and down through that. Very experienced clinician and educator. We're pleased for him to bring this to us today. It's important I disclose to you that he is a paid speaker for Tulsa Dental. He is not an employee, however, or in any other regard, so he is paid for this particular presentation. But I think you're going to find this very valuable on case selection. Dr. Kinra, please.
Thank you, John. Again, hello. My name is Diwakar Kinra. I am an endodontist practicing in Flint, Michigan. I would like to thank you for joining me today on our session on case selection. In this segment, we're going to go through a stepwise checklist on how to determine the level of difficulty on endodontic cases. After completion of this webinar, you should be able to decipher which cases can be seen comfortably, safely, and efficiently in your practice. Also, I will highlight areas where you may be able to address cases in the more highly difficult category and make them more manageable in your office. Therefore, in the long run, being able to see more cases in-house and becoming more profitable. Today's theme, let's talk about that, is going to be about challenging yourself. What I want you to do is think about all the cases that you are comfortable treating in your office, and then determine what keeps you from seeing more difficult cases in your office. And since you are the gatekeeper of your patients, you have the honor of cherry picking the best cases to keep in your practice. This will showcase your skills and build a great patient referral base. A well done, comfortable root canal is one of the best procedures to highlight your abilities as a dentist. Let's determine what's a good case to keep in-house and what cases are better served in the endodontist office. Now, I personally know a little bit about something about challenging myself. I was a GP for 3 years, and I went back to specialize in endodontics at the University of Detroit Mercy. I went with one child. Anybody who goes back to school with one child or any children, I applaud them. It's very difficult. When I left, after 2 years of being there, getting my master's, I left with 4 children. So I definitely know something about challenging myself, and hopefully I can relay that today in endodontics. The majority of this lecture is based off the 2006 AAE Endodontic Case Difficulty Assessment form. You should be able to download this form before starting this webinar. This is a critical form. It's going to be our handout for the lecture today, so please do so if you haven't done so far. And this form is critical in determining whether a case should be seen in your office or should be referred to the specialist. And I like to take this one step further. If we break down the form, the criteria and sub-criteria can be seen along the left-hand side, and the level of difficulty can be seen along the top. The more criteria that falls into the highly difficult category, the more chances you want to refer that case to a specialist. And if we take a look at this, this is the way I look at these cases. A minimal difficult case should be the case that is a slam dunk in your office. These cases are routine cases that should be completed in one visit. And a well-done single-visit root canal, as I said, is one of the most profitable procedures in dentistry. Therefore, these are your great practice builders. And I'm going to give these cases 3 stars. Okay. Moderately difficult cases are ones that may present with more challenges in certain categories. This may hinder your caseload or may become an unnecessary burden on your day. And lastly, difficult cases, and I'm going to give those cases actually 2 stars. And those difficult cases, in this extremely difficult, this last section here, those are the ones that are going to be not started or managed in your office due to the safety of the patient and unpredictability of the outcome of the case. These cases also can become very unprofitable, and no one wants to refer a patient in the middle of treatment. It makes for an unhappy patient and can strain the relationship between the specialist and the general dentist. And I gotta say that you don't want to send these cases because the patient becomes uncomfortable. They're upset a little bit because now they have to go somewhere else. And again, if you do something good for a patient, they'll tell 3 other people. If you do something bad for a patient, they'll probably tell 10 other people. So these are not great practice builders. So these are the cases that I'm going to give 1 star. And hopefully after today's lecture, we can learn how to identify some of these difficulties and move them from the moderately or highly difficult categories to the minimally difficult category. And these pearls will allow you to see more patients in your practice. So let's take a look at the considerations that are on this list. There's 3 types of considerations that we're going to look at today. One is patient considerations. The next is diagnostic and treatment considerations. And lastly, additional considerations. When we take a little further look at our patient considerations, these are the 6 categories that I want to highlight. One being medical history, anesthesia, and patient disposition. We'll round out this section with the ability to open the mouth, otherwise known as limited access, a gag reflex, and emergency condition. When we look at diagnostic and treatment considerations, this is actually something to do with a tooth in hand here, and that's what may limit us from seeing these patients in our practice. Diagnosis and radiographic difficulties, position in the arch. As we go further back in the arch, the tooth does become more difficult to treat. We need to know how to do tooth isolation. And the next 3, I kind of rope them into one, is morphologic aberrations of the crown, canal and root morphology, and radiographic appearance of the canal. Lastly, we will talk about resorption. Not about treating resorption, but how to recognize resorption. And the last consideration that we're going to take into account are these additional considerations, such as trauma history, endodontic treatment history, and the perio-endo condition. Let's go into patient considerations. When we're taking a look at patient considerations, the first one on our list was medical history. Let's dive into medical history. If anybody knows medical history better than any of our clinicians out there, are going to be the general dentists who see the patient every 6 months. Again, those ASA class 1 patients are our slam dunk 3-star type patients. As you get further along, ASA class 2, 3, 4, 5, they become more difficult. Now, I'm not trying to tell you that you can move a patient from ASA class 3 or 4 to ASA class 1, but we can learn how to deal with these patients a little bit more straightforward. There's 2 ways to do this. Well, first we need to understand what exactly is ASA class 1, 2, 3, 4, and 5. And once we have a good understanding of that, a review of that either through a course that you can take, continuing education. If you don't have time to do that, then I would suggest you take a little bit of a review from this book right here. It's Little and Felice's Dental Management of the Medically Compromised Patient. This will really help you understand your patient's medical history and how to better treat those ASA class 2, 3, and 4 patients so they will become more simple and you can treat them in your office and you don't have to refer them. Anesthesia. Well, this is one of the most challenging parts of the root canal procedure. Again, there's patients who have no history of anesthesia problems. These are our 3-star patients. But there are those patients who have vasoconstrictor intolerance or epinephrine allergies, as they like to tell you, or difficulty achieving anesthesia. Well, those are our more challenging patients that fall into these 2 categories. What I also like to do is make sure that I put a patient who has difficulty achieving anesthesia on the lower mandibular arch, such as an irreversible pulpitis. You may want to put those in the more difficult category. But in reality, the bar is set very low for endodontics. And the reason being is anesthesia is one of the more challenging parts of the procedure. And the patients come in with low expectations, and some of us take that as a challenge. Well, I take that as an opportunity. How am I going to make myself better in these situations? How can I improve the patient's perception of anesthesia? Well, because the bar is set so low, it's set so low for two reasons. One, the patient has fear of getting anesthesia. And two, they're a little bit fearful that the procedure is going to hurt. So if we have profound anesthesia and we give it comfortably, we've raised the bar. And that's a huge accomplishment for dealing with these patients. If we just go a little bit above their expectations, we are now their hero. So what do I want to do? I want to make sure the patient is completely numb. And to do that, I test for anesthesia. I make sure they have no feeling in that tooth before starting. And I do that with endo ice. So every patient, after I've numbed them up, I do not trust their lip signs. I do not trust soft tissue sticks. What I do trust is making sure that I put endo ice on a cotton tip applicator and then place it on the tooth in question. When I do that, I'm very comfortable knowing if the patient is numb. Okay, they feel comfortable because now I've tested it. They're very appreciative of that, and that I'm not going to hurt them. That gives them a little bit more confidence. But what happens when the patient says, doc, I still feel that? Well, I don't go and re-anesthetize because if they have lip signs and tongue signs and they're comfortably numb and they do have those soft tissue sticks, I know that I've administered the local anesthetic correctly. So now it's time for supplemental injections. Okay? And this is what I call time for an intra injection. And these are the three type of intra injections that I'm going to perform when I want to get that patient numb if they still feel the endo ice.
Dr.
So
Kinra,
here are the three.
let me
Yeah.
pull something on screen real quick since we're partway into this. This will be the assessment form you mentioned for people to download. And this is a live link, even for those of you watching the recording. I'll leave that on screen for just a few slides here while Dr. Kinra continues.
Okay, that's a great way to manage that if you need to get a copy of that. As I said, this is where I'm looking at the three types of supplemental injections: intraosseous, intraligamentary, and intrapulpal after an IAN block that has not accomplished complete analgesia of the tooth. Let's review those. An IAN block that fails or doesn't achieve complete analgesia, I'm going to go ahead and do an intraosseous injection. Now, whether you use a Stabident or X-tip does not matter to me, but you have to do it in the correct manner. The first time I ever used this, I never had a good result because I wasn't doing it correctly. I was performing it in unattached gingiva. I wasn't placing the needle correctly. But when you place the cannula distal to the tooth that you're concerned about, and in the bone, it distal, and then also you want to make sure that it's an attached gingiva, you get a good result. And you have to place that cannula right there. And as you see, now you have to use the needle provided in the packaging. And the needle provided in the packaging is a short needle that then gives back pressure. That back pressure is what's going to give the analgesia effect. And it gives a great way of getting supplemental anesthesia. I get over 90% is shown in the research that shows that you can get profound anesthesia. And to get better back pressure, what do I use? Well, since I'm an endodontist, I know how to use endodontic material such as a hand file here. I'm going to take the rubber stopper off that and place it on the needle. And that right there, if you put it in that spot, you're going to get great back pressure. And that will give you that profound anesthesia that you can go ahead and then retest with endo ice. You get a negative response. It's time to get started. What's another type of anesthesia that we can use? Well, the intraligamentary anesthesia, or we use this is an PDL type of injection. You can use a Ligajet, but again, what do is I make sure that the needle is in the sulcus. Either it's on the buccal and lingual that I give it, or on the mesial and distal, depending on the tooth. And I depress 0.2 mLs of anesthesia. And you're going to get maybe some ischemia or some blanching of the tissue, and that's when you know it's working. And then lastly, the intrapulpal. Now, this is not one of my favorite injections to give. Why? Because it's uncomfortable to the patient. But I want to make sure that the patient is comfortable throughout the rest of the procedure. So if I do get into the pulp chamber and the patient does feel it, I'm going to take the needle and I'm going to place that into the chamber until I get resistance, hopefully within the canal. And once I get resistance, I tell the patient, this is going to be uncomfortable. This is going to be painful for a few seconds, but this is going to help you get through the whole procedure without having pain the whole time. So the patient at that time is thinking, okay, well, the doc is doing this. It's going to hurt for a few seconds, but the rest of the procedure should be comfortable. At the end of the procedure, I remind them, I say, I'm sorry that I had to give you that type of anesthesia, but hopefully you were comfortable the rest of the time. And that's what they remember when they leave. Yes, I did have to endure a few seconds of discomfort, but then I was comfortable the rest of the time. And that's what they're going to leave with. Patient's disposition. Well, again, getting patients numb, sometimes just getting them numb is uncomfortable for them. They need a little bit of help here. And in many cases, you have cooperative and compliant patients. Those are my 3-star patients. Yes. And in most cases, that's most of my patients. I do have some anxious patients, and then when they become uncooperative, you have to go to the next level. Sometimes I use Valium or Xanax to help the patient out. I make sure the patient has a driver if that's the situation. Again, but if you want to go to the next level, how do you make those patients a little bit more comfortable? How can you keep more uncooperative patients in your office? Well, many of us are using nitrous oxide, and that's a great way to start. But a lot of us who I've seen are some of my most successful referring general dentists are taking a doc's education course. This oral conscious sedation course has gotten great reviews. Everybody who comes back from it says that they're just able to handle a lot more different types of patients in their office. It's something that you can bill for. It's something that also is a great practice builder. I've seen these dentists become very busy because this community knows each other and they refer a lot of patients. And if you are one of those patients that is very nervous or can become uncooperative, and you can get a lot of work done by going to one dentist that can take care of everything, this is a great way to build a practice. So think about taking a doc's education course to help you deal with more challenging type of patients. Ability to open the mouth. Well, this is a limited access issue. And there's a couple different tricks that we use in our office to get through this type of procedure for the patient. The patient even tells you, doc, I can't open up very much. How are you going to be able to deal with that? Well, this is the thing that I look for. There are some patients who have limited access, which may be considered slight, okay? And again, once you numb them up, sometimes that opens up. Again, limited access, such as they can't open the mouth up and you're worried about getting into a second molar. Well, this is what I do and what I look for. Okay, how do you make these patients easier? Well, the first thing I do is I see if I can get my 2 forefingers in the patient's mouth. So if you take a look at here, if I get the 2 forefingers in there, I can work on almost any tooth in either arch. And really what sometimes the issue is not that when we start the case, is that as the case proceeds or goes on, it can become the length of the procedure that determines whether they can keep their mouth open or not. So in most of these cases, I will then go ahead and use a bite block. Now you may need to use a pediatric bite block or an adult small, but those are very critical in keeping the patient open. Again, the next thing I will use is that in conjunction with the bite block, I will use a rubber dam. I want to use a rubber dam for many reasons, but in this situation, I want to use a rubber dam because it speeds up the procedure. And if it speeds up the procedure, because now I can see better, I don't have to fight with the tongue or the buccal mucosa, I can get the procedure done quicker and limiting the patient's fatigue. If we limit the patient's fatigue, we can keep them open for a little bit, while we're doing the procedure. And in rare opportunities, I will use a mouth prop. And this is something that I will use only if necessary, but because that you can do damage to the patient's jaw, I'm a little bit more careful using this in my procedure. So again, bite block, rubber dam, get that patient opened up. In many cases, a pediatric rubber dam will help. And I start off with the pediatric rubber dam, get the patient used to that, and then sometimes I switch them over to the adult small to keep them open. Gag reflex. Now this is one of those situations there I have a hard time with, because I do not want to see the patient gag because then it makes me gag. So again, those 3-star patients are ones that don't gag at all. Again, you'll always have that patient that, if you do a do some X-rays and do some radiographs and the patient is uncomfortable, they might gag during that, but they might not gag the rest of the time. And then also, you have that one that compromises dental treatment. Those are the ones that I'm concerned about. Now, again, there's a couple different tricks that we use in our office to get these patients through the procedure. And sometimes just numbing them up helps, okay? But what I like to use is this product right here, Hurricane Topical Anesthetic Spray. Now, I'll take that 20% benzocaine oral anesthetic, and I'll spray it back where the junction of the hard and soft palate, and I get a really great response. And I don't have to worry about that patient gagging, and I can get my procedure done quickly. Again, using a rubber dam in these situations keeps a lot of that irrigant and water out of the back of the patient's throat and makes the procedure go that much quicker and more comfortable for the patient. Emergency condition. Again, you are the gatekeepers of your practice. So you're going to have patients that come in that have some pain and swelling. Again, our minimal pain and swelling type patients, those are our 3-star, easy to deal with patients in most cases. But once they get moderate pain and swelling or severe pain and swelling, then I'm a little bit concerned about those patients because you don't want to just send them out of your office and not get them into maybe a specialist office right away. If you can handle that in your own practice, again, a great practice builder. So this is what I want you to do in those type of situations to make your life a little bit easier. Let's take a look at these next few slides here. And I want you to be able to perform an IND when a patient comes in that's swollen. So take a look at this slide here and you'll see that I want you to go ahead and use a 15 blade and make sure that the patient is profoundly numb. And then I want you to make sure that I just not a little poke to be able to get some exudate out of there. And then I want you to go in with a blunt instrument like a hemostat or a perio elevator, and I want to make sure that you get some good release of that swelling. When you see that occur, then I want you to take something like a sterile rubber dam and suture that into the lesion there so that it can continue to drain throughout the next day or two. I want you to have that patient back within 48 hours and take that out. Okay, but I want you to have good drainage there. On that same day, the tooth in question, I am going to open that tooth up. So I'm going to bill for an IND, the first appointment, and then I'm going to bill for the root canal, the second appointment. And I want you to get infection, exudate, pus, blood, anything out of the tooth so you know you're going to have a good result. And if you take a look at that, this is what you should see that day. Okay? And so what happens when you end up with a case like this? You open it up and there's exudate coming out and you're like, well, I got to get this under control. Well, this is the little trick that I want you to use. I want you to use this exact instrument here. It's by Ultradent. It's a high evacuation suction. And this high evacuation suction has an adapter. This adapter then goes to this capillary tip right here. And this capillary tip can be then placed into the tooth right here to help expedite the suction. And that really does help clear out a lot of that exudate with this capillary tip. At that point, once I've got a lot of drainage out of the tooth, I will then go ahead and use this calcium hydroxide. It is also by Ultradent. I like using it because the delivery device. It's through a syringe that has a flexible tip. It has a stopper so that you make sure you keep the calcium hydroxide within the canal. And then it is the highest pH that's out there of 12.1. So it really helps, disinfect that canal very effectively. And then I have the patient come back in about 3 weeks. And then I see a big difference in that patient. I see the swelling has decreased. And then also that the patient is much more comfortable, allowing me usually to finish a root canal that visit. So as you can see here, this is how I would handle an emergency condition. I think this is a great way. We've talked about the patient consideration in the first section here. And now I want to go on to the next diagnostic and treatment considerations. Okay. In the beginning, diagnosis is extremely important. And I think the issue is that many clinicians get themselves in trouble here. And why do they get themselves in trouble? It's because we don't perform diagnosis the same way on every patient. Because in many cases, when a patient comes in for a root canal, it's very obvious what tooth is in question. And because of that, sometimes we slack a little bit and don't do diagnosis the exact same way on every patient. But it should be systematic. It should be the same way for every patient. And if you do that, you're going to make less mistakes. So again, our 3-star patients are those ones where the signs and symptoms are consistent with the pulpal and periapical conditions. As those signs and symptoms become more difficult, they become a little bit more challenging. And that's why we need a systematic way of doing that. So let's take a look at how can we make our lives easier. Well, what are we trying to do in diagnosis? We're going to take the patient's chief complaint, that we need to write that down every single time. And then we need to, again, reproduce the patient's chief complaint. Once we've reproduced the patient's chief complaint, we need to determine the cause. And once we've determined the cause, we need to know how to figure out how to eliminate the cause. So let's go into our systematic way of doing diagnosis the same way on every patient. Again, I think that there needs to be an endodontic diagnosis on every major dental procedure that you do. So if you do a crown, you need to have an endodontic diagnosis. If you do an MOD, a large amalgam, a large composite, you need to have an endodontic diagnosis. Now, we have a periodontal diagnosis on every tooth, but sometimes we don't have an endodontic diagnosis. So to keep yourself out of trouble, an endodontic diagnosis on major restorative procedures is a great idea. A lot of things have changed in dentistry, but one thing that hasn't changed is the SOAP format. Again, SOAP. What does that stand for? Subjective information, that's the S. That's the patient's point of view of what's going on in their mouth. This is their side of the story. O, objective findings. That's our point of view. That's the doctor's point of view. And what do we do with that? We have a clinical exam that we perform, and then a radiographic assessment, and then we do our comparative testing from the information that we gathered from the patient during the subjective information interview. And then next, assessment. This is basically our diagnosis, which is twofold. You'll get a pulpal diagnosis and a periapical diagnosis. And lastly, now that we've determined the cause of the problem, we have to find out how we're going to eliminate that cause. And that's what our plan of treatment is. Is it going to be extraction? Is it going to be a root canal therapy? That's what we're going to determine next. Let's go into the subjective information. This is, again, the patient side of the story. This is our interview with the patient. These are the questions I want you to ask them so that you can come up with the information you're going to need to perform your objective information. 1, history of pain. When did this pain start? Did it start recently? Has it been going on for a long time? Did it start with some trauma? Or was it due to some dental procedure that they may have done recently? Doc, every time since we did that large restoration, that large filling that we did on the upper left, I've been having issues. You told me it was deep. You told me that it was going to be a problem. Well, you were right. Okay, so these are the information that I want you to gather as far as history. Then, stimulus of pain. This is extremely important. What brings on your discomfort? And this is important because this tells you then, again, what comparative tests we need to do. So if they say it's pain to cold, pain to hot, then what do we need to do? We need to reproduce that patient's chief complaint by introducing cold and hot. If they say it's pain to biting or chewing, we need to, again, reproduce that chief complaint. And then severity of the pain. I like to put a number with the patient's pain. So what I ask them is, give me a number between 0 and 10 that describes your pain. Why? Because I want to quantify the number that they're having. So if they tell me it's a 9 out of 10, I say, okay, I'm going to write that down, because if the next time they come in, they go, I'm still having pain. Well, what is it today? Well, it's a 2 today. Well, we're definitely going in the right direction, okay? So we want to make sure that we write that number down so that we can compare the effect that we've done from our treatment. And again, what's one person's 5 might be another person's 7 or another person's 3 because pain is very subjective. And then I want to ask them the frequency of the pain. How often does it occur? Does it occur all the time? Does it occur only after eating, only after ingesting cold or hot? Does it occur when they wake up in the morning? Is it more of a clenching issue, or does it occur at nighttime? So that kind of gives me an idea of where this pain is coming from and what is causing it. Next, duration of pain. This is extremely important because this really helps us determine what we're going to do next. And if you have a stimulus of pain, and how long does the pain last after that stimulus? Well, it lasts at least 30 seconds or longer. Then we have irreversible damage. That means it's time for the root canal. Okay, but if the pain is less than 30 seconds, well, that could be something else. That might be still in the reversible stage. We might be able to do a restoration or cover some exposed dentin or deal with some root caries that might be causing this type of pain. So not every case is going to be a root canal. Again, when we're looking to eliminate the cause, root canal therapy is just one of our choices. Location of pain. Again, if we can't decide which arch the pain is coming from, which side of the midline the pain is coming from, we can't do any work. If we can't localize it to one quadrant, we can't do any work. We have to localize it to one tooth. And when we can localize it to one tooth, then we can go ahead and proceed with our root canal therapy if that's what's going to solve the patient's problem. Spontaneity of pain. Here again, I just want to see if it's spontaneous or non-spontaneous. And lastly, I'm looking at nature of pain. I want to look and ask the patient, why don't you use some descriptor words to describe the discomfort you're having? And if they tell me, doc, it's burning, it's shooting, it's dull, these are words that are describing their pain that I'm going to write down because when they come back, I'm going to ask them the same type of questions. What's the nature of your pain? And if they're not using those words, then maybe we have resolved their problem and there might be another issue at hand. So this rounds out the subjective information that I'm going to want to ask the patient. And now it's time, once I've got their side of the story, is to come up with my own side of the story. And so here I'm looking at 3 things. 1, a clinical examination, a radiographic assessment, and then some comparative testing. So again, I don't want to start my review with a patient by heading at them with instruments. So I'm going to go at them with my finger, something non-invasive. And so I'm just going to use my fingers to do a clinical exam. Now, you're all very good at doing clinical exams. You do them every day after a hygiene check. So we know you know how to do a clinical exam. So I'm going to go ahead and do a screening with my fingers. I'm going to look for any lumps or bumps inside the buccal mucosa or on the palate that might focus me on one area. Once I've done that, I'm going to use my mirror handle and I'm going to start to percuss. And I'm usually going to percuss in the opposite arch just to get them accustomed to what's normal. But the last thing you want to do is slam on the tooth that's in question and elicit that pain right off the bat. That's not how you want to start the clinical exam. You want to go ahead and get them accustomed to what's normal and then work towards the tooth in question. Again, if you have percussion pain, this is very indicative of my periapical diagnosis. Percussion pain equals damage. And so that really helps me focus on what the problem is. Again, I'm going to use 2 mirror handles then to look at mobility. Mobility is, I don't want to have the give of my fingers trick me into how mobile that tooth may be. And I'm going to write down the class of mobility, class 1, 2, or 3, because again, sometimes that can be coming from endodontic infection, but sometimes we have to look at our perio condition too to make sure that's stable and can withstand an endodontic procedure. Again, after we've done our clinical test, we're going to go ahead and take radiographs. I want you to take 2 radiographs, one straight on and one angled to get a good idea of what's going on radiographically with that patient's tooth. Then I want you to do comparative testing. So if the patient tells you what stimulus brings on the pain, such as thermal, hot or cold, then I want to test for hot and cold. And how do I test for cold? Well, I use Endo ice. I like using this refrigerant because it provides a very cold response as compared to maybe cold water or blowing air or even an ice stick. Now, I've heard of some people who use a keyboard cleaner or electronic dust cleaner, and they turn it upside down, and it gives the same refrigerant effect as Endo ice. Now, I will take that Endo ice, and some people put it on a cotton pellet. Now, and I actually like to put it on a cotton tip applicator. Why? Because the cotton is has a little bit more density and can hold the cold for longer, which is exactly what I wanted to do, because I want to get a real response here. I don't want to get a false response. And that's how I would test for endo or for cold. And again, I use this again to test for anesthesia too. So I use that same cotton tip applicator after I've numbed the patient up. So I want to make sure that this is a great way to test the vitality of the tooth. Again, if it lasts for more than 30 seconds, irreversible damage. Hot's a little bit more difficult to test for. Hot, some people use a touch and heat. I'm not a huge fan of that. I will use the adapter from a Calamus unit because that really is meant for testing hot on a tooth. Again, one of my favorites is probably using just warm gutta percha. And if I am going to use warm gutta percha, I'm going to make sure I do that with a little bit of petroleum jelly so that I don't, can't get it off the patient's tooth if they do feel the hot. That's the last thing you want to do is have them screaming from the hot pain and you can't get it off the tooth. Again, I will go as far as isolating the tooth without even anesthesia and bathing it with some hot water or coffee because we always have hot coffee in the office. If they say every time I drink my hot coffee, it hurts, well, this is the best way of reproducing that chief complaint. Now, we all have those patients that come in with a cold, cup of ice or cold water, and they say, Doc, I got to keep this cold water on my tooth to keep it comfortable. Well, those patients can be difficult to assess sometimes. So what do I do in those situations is that I take maybe a cup of maybe lukewarm water or slightly warm water, and I tell the patient to drink that. And they go, oh, that sets it off pretty good. And then what I'll do is take my endo ice and put it on that cotton tip applicator and put it on each tooth in that quadrant until the patient gets relief. And when they get relief, then I said, that's the tooth in question. So that's a little trick you can use on more challenging cases to determine where the pain is coming from, is use that little trick to isolate the tooth in question. So also, when I'm working on my comparative testing and clinical exam, I use a periodontal probe to see if there's any chances of fracture. Now again, generalized periodontal disease we know can be a problem. A periodontal abscess can definitely be an issue and sometimes gets confused with an endodontic abscess. So we need to make sure we test for vitality to rule that out. Again, a periodontal probe helps me look for fractures beneath the gingiva. So I'm going to look for a narrow-based localized periodontal defect. So I'm going to use a probe, and if it drops down all of a sudden in one area, I know that I have a problem there, and that endodontic treatment may not eliminate the cause. And again, that's not what we want to do. Also, I will use that cotton tip applicator that I just used for endo ice, and I will turn it around and use the wood portion of that and have the patient bite down on each tooth in that quadrant. And if they specify one tooth that's uncomfortable, then I will go and use this next instrument here, the tooth sleuth, to see if there's a fracture above the gingiva. So I use a probe for below the gingiva and the tooth sleuth for above the gingiva. And that's how I look for fractures in people's teeth before I move on to endodontic treatment. So what have we done here? We've gotten the subjective information, the patient side of the story, and we've gotten the objective information, the clinician side of the story, and we meld those two together to come up with the assessment. At this point, we're going to get a pulpal diagnosis and a periapical diagnosis. Our pulpal diagnosis is going to consist of a normal pulp, reversible or irreversible damage, or necrosis. Our periapical will account for maybe acute apical periodontitis or chronic apical periodontitis. Again, if I had more time, I would go into this. If this was a diagnosis course, we're going to break those down much further. And I think even if you go online onto Dentsply's website, you'll see that they have a great diagnosis lecture done by George Bruder, which does a great job at really pinpointing diagnosis. Again, now that I've reproduced a patient's chief complaint, we have to find a way to eliminate the cause. And that's where we're going to come up with our plan of treatment. Sometimes it's just covering the dentin with a restoration. Sometimes it's going to be extraction. But if root canal therapy is what's going to help the patient, that's what we're going to do next. Radiographic difficulties. Well, again, I think what I said was during the clinical exam, you're going to need to take radiographs. And many times, our 3-star patients, they're going to be have minimal difficulties and they're easy to interpret the radiograph. But as it gets more challenging, it can be a little bit more difficult to even obtain the radiographs and then interpret them. How do we deal with this? I know that radiographs are extremely important, and I make sure that I am also conscious of the patient's concerns about radiation and such. So I take minimal amount of radiographs, but it has to be thorough. So at minimum, 2 radiographs for the tooth in question. And then I make sure that I'm not using plain film anymore, because I think that if we switch over to digital radiography, it really does help with interpretation, because you can manipulate that X-ray quite easily on the screen. If there is a need to take an additional X-ray, the dosage is minimized. And it really does help you compare pictures side by side when you can place them. And when the patient comes back for a post-op, I am so happy to show these pictures to the patient, because it's a great educational tool. Much easier than I can use a plain film for. Position the arch. I have to say that, as we go back further in the arch, the tooth, just the anatomy becomes more difficult. It becomes more challenging to do the root canal. And in reality, again, our anterior and premolar cases are pretty straightforward, but even those can become complicated. And as we go back further in the arch, it becomes challenging. There's only one way to help you out in these types of situations, and that is practice and spending more time on refining your skills. And the only way that you can do that is spending quality time on hands-on continuing education. Now, even though I went through residency for 2 years, that's not where it stopped for me in endodontics. I've taken the time to spend hours and hours with clinical masters that are out there. Take a course with a Steve Buchanan. Take a course with a Cliff Ruddle, because these clinicians will teach you more than you could ever imagine. And if you can go to one of their lab courses and take a hands-on course, I think that you will learn more than anything you can learn in a book. You're already doing the right thing, but by being online, there's lots of great things on this website. But spending time doing hands-on courses, getting one-on-one feedback is invaluable. Again, if you don't have the time to go and do a hands-on course at a lab course at one of these clinicians' venues, then go to your local dental society, state dental society, or national dental society and take some continuing education. The ADA has great continuing education. And even if you are ready to go and take a hands-on course, Dentsply has courses all over the country. 1- and 2-day hands-on courses are available. This year, over 40,000 people took hands-on education and clinical education from Dentsply. So I have to say that's a great opportunity for you to get that. And hopefully you'll be able to see a live feed of their calendar online and see what's the next course and sign up for one. Tooth isolation. I have to say that using a rubber dam is a great way to improve your outcomes right off the bat. If you want to improve your success, use a rubber dam. Now, routine rubber dam is pretty straightforward. Those are the ones that are our slam dunk 3-star type of patients that you can easily get a rubber dam onto. Again, sometimes you have to do modifications. Sometimes you have to address certain parts of the rubber dam that might be leaking. But I think a lot of us did not use rubber dams because of the way they were taught in dental school. Again, when I was a GP, for 3 years coming out of dental school, I wasn't a huge fan of rubber dams because I had to do quadrant isolation in dental school, and I never got accustomed to, why do I need to quadrant isolate for a root canal? Well, it shouldn't be that difficult. And if you take a look at this video here, you'll see that this is courtesy of a great clinician, Dr. Sean Velez. He's done this video here that shows how easy it should be to place the rubber dam. Now, in this video, you'll see that isolation should take less than 30 seconds. Now, you'll see here that the rubber dam hole, clamp, frame, and material is all in one piece. And you can see here, a doctor has just inverted that right over the tooth in question. Now, that whole procedure took less than 30 seconds. And that's how long it should take to do the whole procedure. Because again, that's how long the video is. And so I know that this isn't do. It will help you with your clinical success rates. And it's something that, is much easier than isolation of the whole quadrant. Again, you may have to do some modifications. And this is something that I will do if I do have some leakage. As you see, the rubber dam material is blue here, and we have some leakage right here. I will place this material right here, or a seal caulking material, and this will help. It's like a putty that you place right along this leakage here, and you can form it with your fingers, and that does a couple things. One, it isolates the tooth 360 degrees around their whole circumference. And also that hermetic seal will do two things. It will make sure that the oral contamination from the saliva does not enter into the tooth. And two, I am a huge fan of using sodium hypochlorite. And using sodium hypochlorite at full strength, I only feel comfortable doing that if we have complete dental dam isolation. So do that to improve your cases right off the bat, starting tomorrow. The next 3 sections here, I kind of group them together. We have morphologic aberrations of the crown. What do we mean by that? Well, again, if the tooth has its original morphology, it has maybe a small restoration in it, these are pretty straightforward. Okay, those are our 3-star cases. But once we start having to work through crowns, bridges, extensive caries, and the original anatomy is destroyed, that becomes more difficult. And how do we deal with these type of cases? Well, this is how you can make your life easier. Again, every one of my cases is done under a microscope because I like to get some magnification and illumination on the tooth. Well, I understand that not everyone can have a microscope, and I am completely comfortable with that. But what everyone can have is a magnified mirror. Take a 2 times magnified mirror, and you're going to see so much more than you would with a regular mirror. So again, magnification is extremely important. Sometimes you need just illumination. So I like using this mirror right here, which is made by Zirc. Now this mirror can reflect light at 40% times a normal mirror. Again, you go online, I looked at this. This mirror is around $6 a mirror head the last time I looked. So it's not very expensive, and it's easy to put right into your practice. So again, you should be using some form of illumination and magnification. Many of us use our loops and light, but again, if you add to that by getting a magnified mirror or a better mirror handle, you're going to just see that much more. Canal and root morphology. Okay? The first part is just about recognizing the canal and root morphology. Again, our 3-star patients are ones that have minimal curvatures or closed apices. But as we get a little bit more challenging, such as an S-shaped curve or an extreme curve or multiple canals or multiple rooted teeth, or long teeth, or teeth that have canal divisions, these become more challenging. And the first point I'm trying to make is, how do we understand this? Is by just recognizing that. So let's take a look at this radiograph and how do we make it easier? Now, if we take a look at these two radiographs here, let's concentrate first on the radiograph on the bottom. Now, if we take a look at this radiograph on the bottom here, and we take a look, and I'm concentrating on this premolar. If we take a look at this straight on x-ray, it looks, pretty straightforward. But that's why I want you to take two films, one straight on and one angled. And when you take a look at the angled film, you'll see here that you have a canal, a chamber, and then all of a sudden it disappears. And when it disappears, that usually means that there's a bifurcation. Well, when we take a look at this tooth, we can look at the outline. We'll say, okay, here's maybe one canal, maybe here's a second, and here's a third. Now, when we take a look after we did the case, yes, there was 3 canals. And maybe entering that tooth right off the bat may have not been a great decision. But now that you may have wanted to refer that one to a specialist, because we looked under the microscope and yes, 3 canals right off the bat, and they were pretty straightforward to see once you got into the tooth. Let's take a look at this top tooth here. Again, straight on, if we take a look at this mandibular molar, okay, it looks like there might be some curvature there, but after you do the work, oh wow, that's a curve that maybe you don't want to mess with, okay? But maybe now that you go back and look at that case, oh, maybe that curvature is something that you don't want to handle in your office. So those are all good information as far as just recognition of what's going on there. If we take a look at this tooth right here, recognition that, okay, in this pulp chamber, we have a stone that we need to be concerned about. We have actually a pretty long tooth that has calcification along the distal, and then quite amount of curvature on the mesial, which then maybe comes back on itself, so an S-shaped curve. Same with this tooth right here. When we did this tooth, yes, it's got a curvature here, but then it curves back on itself, and that S-shaped curve, those can be a little bit more challenging to deal with. If we take a look at this next case here, we can say just recognition that, okay, this mandibular premolar, most premolars are pretty straightforward, but look at this case right here. All of a sudden, the canal disappears, just like it would in this case. And when we take a look at that, how many roots are there? Well, I can see one root maybe here, maybe another here, and then this outline here. Well, after you do the case, those can be quite challenging. And that kind of falls onto the radiographic appearance of the canal. When we take a look at this, let's take a look at this. Those 3-star cases are our canals that are visible, okay? And those are our favorite cases to do. But again, when the chamber becomes reduced in size, or the pulp stone, or they become calcified or indistinct canal paths, we need to be a little bit more careful. Well, again, the first part was recognizing it. Now, how do we deal with those type of cases? Well, let's see how we can keep a few more of those cases in our office. And what we need to do is take a look at these cases, like the one that we just looked at, okay? That's a pulp stone that we need to deal with, okay? And when we take a look at this pulp stone, we need to know how to handle that and how to handle this calcification. And again, how to handle this maxillary central incisor, that calcification there. We have to be very careful with these types of situations because we don't want to have any file separation or cause any problems. Well, the way that we can be safe in our ability to treat a calcified canal is by creating a glide path. Again, if you go online, even on this website, we have some great continuing education on how to create a glide path. But I'm going to give you my short way of this, how to pre-flare the canal. Now, in many cases, we were using hand files. And I'm okay using a stainless steel hand file when they're smaller. I'll use a 10 stainless steel hand file. And in some cases, I'll even go up to a 15 stainless steel hand file. But rarely will I use a 20 stainless steel hand file. The reason being that as we increase the size with our hand files, we have some issues. One, they create ledges and apical transportations. That's what I do not want to do. And that's because of the tip of the instrument and the stiffness of the metal can create those problems. And once that error occurs, before we even get to working length, that's going to be an error that's going to accumulate throughout the procedure. And when an error accumulates throughout the procedure, it snowballs into a very negative outcome. So I always say, if you can get to working length without creating an error, the rest of it is a piece of cake. So using our large shaping instruments, whatever you use, you're using a Pro Taper, a Wave 1, a Vortex, I'm not concerned about that. I'm concerned about getting to working length and not creating a ledge or an apical transportation. Again, I always start off with this 10 stainless steel hand instrument, but then I want to go from stainless steel to nickel titanium. So I will use these files right here, which are the path files, to create my glide path. And nickel titanium is much better and much quicker when used in a rotary instrument to create a very safe glide path, which then you can go ahead and use any shaping instrument you want to after that. I'm not concerned about that. And I use a path file number 1, 2, and 3. So a path file, again, purple, white, and yellow to create a tip size of a 13, 16, and 19. Again, these come in O2 tapers. They come in different lengths, but they don't come in any different tapers. So we know that this is a very safe instrument to use, and it creates a glide path very quickly and then makes your next instrument that much safer. So that's how I would deal with calcified canals and more challenging canals, is to open them up a little bit more before using a shaping instrument. Lastly is resorption. Again, I'm not telling you to actually treat resorption, but able to recognize it and don't get into a case that you may have thought of as maybe caries or something else that's going on with the canal. So again, minimal resorption, extensive resorption, those are, how do we just recognize them? Well, we have two different types of resorptions that we want to discuss. One is internal resorption and external resorption. And how do we tell the difference between the two? Well, internal resorption, as you can see here, there's a lesion here, and that lesion is seen within the canal system. And if you take two films and they both show that that lesion is within the canal system, it's internal resorption. Okay. And in these cases, I'm very conservative. I don't try to do too much work here. And a lot of times I'm electing to extract these and go for the more predictable outcome. In external resorption, if you take two films and that moves a little bit, that resorption, then I'm going to look at that as external resorption. Again, not something that I might want to deal with in my office. I might want to extract that case. So this is just recognition of resorption. Now we've looked at the diagnostic and treatment considerations. And lastly, we're going to wrap up this with one last group of considerations, which is these additional considerations. These are the three that I want to talk about: trauma history, endodontic treatment history, and the perio-endo condition. Let's look at trauma history. Again, more kids are playing sports and they're going to have trauma. And when they're uncomplicated crown fractures, these are our 3-star patients. We can deal with them pretty easily. But guess what? These patients are not coming into my office first. They're coming into your office first. They're calling their dentist because they've had an issue and they want to see you right away. So if you can treat these patients in your office and you know how to deal with them, they're going to love you for the rest of your life. They're going to be dedicated to you, and their whole team will probably come to you if you do a good job with them. Again, when it becomes complicated and they get luxation, subluxation, avulsion, intrusion, extrusion, lateral extrusion, we're going to want to know how to deal with these cases. And to make this easier on your life, I suggest you just do one thing. Go to this website, the Dental Trauma Guide. You find this website. It's a great way on how to deal with trauma. It gives great pictures and schematics and even radiographs on how to deal with these types of issues. And you can see the difference between subluxation and fractures, intrusion, extrusion, and how to deal with each one of these cases, even alveolar fractures. So this is a great resource and tool as far as how to deal with trauma. Endodontic treatment history. We have to understand that sometimes a previously treated case can be very challenging. Again, when they have no previous treatment, are 3-star cases. If they have a previous access by another general dentist or somebody else that you don't know or had it done years ago, that can complicate the procedure. And again, if the patient's had previous treatment, that can also complicate the procedure. So how do we make this easier? Again, recognition is important. This patient walked into the office and was there for a consult because they wanted to make sure that they were going to extract the tooth because they said that every time that the patient bit down, it hurt. Well, what do we recognize in this case right off the bat? One is that, yes, there's definitely a lesion on this at the apex. But when I went around and did probing depth, I could not find anything that would indicate a fracture. And just because there's pain to biting doesn't always mean that it's fractured. But if we take a look at this case in some detail, you'll see that the gut aperture, they found 3 canals. This is a maxillary first molar. And I'm not too concerned. The palatal canal looks okay, pretty decent, and so does the distal buccal. I think we can improve on it a little bit. But if we take a look at this mesial buccal canal, we'll see that the gut aperture looks pretty decent. But when you take a look at the canal, look at where the canal's at here. That root, the outline of the root is this canal is not centered in the outline of the root. And when it's not centered, that means that there's some additional canal space that was missed. So when we go back and look at this and we retreat this, we were able to finish this in a pretty short amount of time compared to if the patient had an extraction, bone grafting and an implant or a bridge. That may take a lot longer. We found additional canal space. We resolved their symptoms. Remember, we reproduced the chief complaint. We eliminated the cause and got the patient back to normal actually pretty quickly. And they were very comfortable. Again, sometimes when the patient comes in and they're looking for some additional help, this patient came in and said, they came in there for an extraction. Okay, we knew that post probably caused a perforation. So we went ahead and took the post out and repaired it with mineral trioxide aggregate or MTA. And look at the result we get in 6 months. So I'm pretty happy with that. And we saved the patient from having an extraction. So sometimes previous treatment we can do good work on and get a great result. The perio-endo condition. This is our last consideration that we need to look at. Again, I talked about this a little earlier, but again, our 3-star patients, they don't have very extensive periodontal disease, but once they get moderate or severe periodontal disease or a cracked tooth, this can be an issue. And how do we deal with these situations? Doing a root canal on a tooth that has extensive periodontal disease, you may not be serving the patient the right plan of treatment. We may not be able to eliminate the cause because the periodontal disease may be an issue. So again, when we take a look at this radiograph here, and I get a deep probing depth on the distal, and the tooth still tests vital, well, guess what? That might be a periodontal problem versus an endodontic problem. It could be both, but in some cases, when you take a look at it, in this case, the surgery was done and the fracture was noted at the time of surgery, that's kind of a little late. You'd hope to find that before we actually do the procedure, okay? Because the last time, or the worst time you want to find it is when you extract the tooth and then you find, the fracture after you've done a root canal and a crown. Well, hopefully you've gotten a lot out of this case selection seminar here. I had the pleasure of speaking to you for the last hour or so. Please take the time to do the quiz and hand in your CE and get the credit for it. And again, sign up for a continuing education class. I think you'll get a lot out of it this next year and learn to challenge yourself. Thank you very much. And sometimes it takes a presidential effort to challenge yourself, and I hope you do so in the near future.
Thank you so much for that. I'm going to just leave this particular screen up. It has your contacts on it. It also has some hyperlinks that we've referred to throughout. So I think those watching even on the recording, you'll see that those are live links. If you'll click on them and then you want to hit the browse to feature, you can do that. And it points to other educational opportunities, including the diagnosis on-demand program that he did refer to. And I'm going to pull very quickly up before we wrap up also that case assessment form for download, and I'll leave that on screen as well. Pull that here. There we go. So Dr. Kinra, once again, thank you for a excellent program. And I'm going to go ahead and stop the recording, and we'll talk to you later.
Thank you very much.